Hello, my name is Edward, and this is my poster on concomitant intravascular volume expansion and IV diuretics to improve outcomes of acute heart failure with low cardiac index. To begin, acute heart failure is associated with poor outcomes, especially in hospital morbidity and mortality. In the treatment of acute heart failure in the hospital, IV diuretics are a mainstay of therapy, but sole therapy with diuretics may be ineffective in the setting of shock due to low cardiac output, especially in the setting of cardiorenal syndrome. Loop diuretics promote intravascular volume depletion and may worsen hypotension in the setting of acute decompensated heart failure. Also, a downstream effect of furosemide use is vasoconstriction in the afferent arteriole due to increased natriuresis sensed by the macula densa, and that may worsen renal perfusion. This is also known as the tubuloglomerular feedback mechanism, which you can see here in figure 1. However, therapy with IV fluids in addition to diuretics in acute heart failure may be helpful to support low blood pressures. We conducted an evidence-based review of the available literature to investigate the possible utility of intravascular volume expansion in acute heart failure therapy. Two reviewers independently searched the PubMed and Cochrane databases for articles published between 2011 and 2021. Search terms were acute heart failure and diuretic and normal saline. We included any original observational or experimental studies and meta-analyses that compared various outcomes between patients treated with furosemide only and patients treated with both furosemide and a crystalloid fluid. As you can see here in Table 1, we came across 5 studies that fit our inclusion criteria, 3 meta-analyses, and 2 prospective cohort studies. All 5 studies studied the effect of adding hypertonic saline solution to sole therapy with loop diuretics on outcomes of acute heart failure. In Figure 2, you can see the various treatment arms that patients were assigned to across the studies. In Yela et al., a prospective cohort study, 28 patients were assigned to 3 therapies: 150 milliliters of 1.95% hypertonic saline solution over 30 minutes and 160 milligrams of furosemide daily, furosemide 160 milligrams over 16 hours daily, or furosemide 80 milligrams 2 times a day. In another prospective cohort study, Paterna et al., 1927 patients were assigned to either treatment with 150 milliliters of 1.4% to 4.6% hypertonic saline solution with 250 milligrams furosemide 2 times a day and 120 millimoles sodium per day, or treatment with just 250 milligrams furosemide 2 times a day and a diet of 80 millimoles sodium per day. With the studies included in the meta-analyses, hypertonic saline solution was used anywhere from a concentration of 1.4% to 7.5%, with variation in dosing and scheduling for loop diuretics for both the hypertonic saline solution group and control group. If you see back here in table 1, you can see that the meta-analyses found that there were improved outcomes in the hypertonic saline solution group, including all-cause mortality, length of hospital stay, hospital readmissions, weight loss, and creatinine change, compared to sole therapy with loop diuretics. Paterna et al. Found that there was a greater decrease in weight in the intervention group compared to the control group, and creatinine decreased in the intervention group but rose in the control group. Yela et al. Found that the intervention group had greater body weight loss over the control group, but this was not statistically significant. There was no significant difference in creatinine change between the two groups. Interesting to note, Kovic et al., one of the meta-analyses, and Paterna et al. Reported a statistically significant higher increase of natriuresis in the hypertonic saline solution group compared to controls, and did not find a significant difference in BNP levels between both groups after treatment. In conclusion, hypertonic saline solution may be an effective adjunctive therapy to IV diuretics. The meta-analyses showed that in general, treatment with hypertonic saline solution led to improved outcomes, while the prospective cohort studies revealed mixed results. Pathophysiologically, hypertonic solution in combination with loop diuretics may attenuate the tubuloglomerular feedback response with increased sodium delivery to macula densa and lead to improved renal outcomes. It does not require a higher intensity of patient monitoring in the hospital setting and may be an efficacious cost-savings alternative to other expensive advanced heart failure therapies. However, there are significant weaknesses in this current study, including homogeneous patient populations, overlap in patient populations, and difficult between study comparisons due to the variability in treatment arms. In the future, further randomized control studies and studies comparing adjunctive hypertonic saline solution therapy to loop diuretics to other advanced heart failure therapies must be done to establish similar outcomes. Thank you.